Welcome to the deep dive. Usually when we talk about fitness or recovering from almost any kind of bodily injury, there's this universal assumption that weakness is the enemy.
Right, yeah. Like if it hurts, just strengthen it.
Exactly. If your knee hurts, strengthen the quads. If your back hurts, build a stronger core. We've been, completely conditioned to assume that the answer to physical dysfunction is always to add tension, like build more muscle and just tighten everything up.
It is a very mechanical or almost industrial way of looking at the human body. We tend to view ourselves as engines that just need to be revved up or, I don't know, bridges that need tighter cables.
Tighten the cables.
Yeah, but biology is rarely that straightforward. And applying that just strengthen it mentality universally, well, it can actually lead to some pretty disastrous clinical outcomes.
Which brings us to today's mission. We are diving into a space where that standard go-to advice specifically, the universal prescription to just do Kegels, can actually make a severe problem exponentially worse.
Oh, absolutely. It's a huge issue.
Yeah, we're exploring the intersection of physical therapy and regenerative medicine for intimate health. We're going to look at how clinicians are combining what's known as pelvic floor down training with this cutting-edge injectable treatment. And here is the hook for you listening, that injectable treatment utilizes highly purified DNA fragments extracted from the gonads of salmon and trout.
I know it sounds totally wild when you first hear it.
It really does, but they use it to biologically regenerate human tissue from the inside out.
Yeah, the underlying science sounds like it belongs in a sci-fi novel, honestly.
Yeah.
But the real-world clinical outcomes are deeply grounded in cellular biology. And to synthesize how these two, vastly different therapies work together, we're pulling from a really fascinating stack of clinical materials today.
We are. We've got clinical insights and treatment protocols from leading physiotherapy clinics, specifically Beyond Basics Physical Therapy and the Pelvic Health and Rehabilitation Center, which is often just called PHRC.
Right, both really well-respected clinics.
Yeah. And we're also integrating clinical FAQs and sequencing protocols from the Women's Health Clinic alongside a highly detailed real-world clinical study published in the journal OA Text. Our goal for you today is to really understand this dual approach to intimate health. We need to look at how clinicians treat both the hardware, meaning the physical mucosal tissue, and the software, which is the muscle memory and the nervous system's response to pain.
And to really grasp why this dual approach is causing such a paradigm shift in intimate health right now, we have to start by deconstructing the software problem first.
Okay, let's get into it.
Because doing that requires completely debunking a massive societal misconception about pelvic floor dysfunction.
Right, let's get right into that misconception. Because according to the clinical data from PHRC and Beyond Basics, when people, and especially women, experience pelvic issues, they almost universally self-diagnose as weak.
Yes, constantly.
Whether they are dealing with, urinary urgency, chronic pelvic pain, or pain during intercourse, which clinicians call dyspareunia, the immediate knee-jerk reaction is just to start doing Kegel exercises.
Which is the worst thing you could do.
Right. They try to tighten an area that is already causing them severe pain.
Exactly. The clinics point out that in a vast majority of these dyspareunia and pelvic pain cases, the symptoms are actually driven by a hypertonic or high-tone pelvic floor.
And for you listening, a hypertonic pelvic floor essentially means a neuromuscular condition where the muscles in the pelvis remain abnormally contracted, like they are constantly guarding.
They're locked up.
Right. They are failing to coordinate properly with basic autonomic functions, like just voiding your bladder or allowing for sexual intercourse.
And the clinical paradox of a hypertonic state, which I think confuses a lot of people, is that it presents as a tight and weak pattern.
Tight and weak, how does that work?
Well, when a muscle is constantly clenched, it restricts its own blood flow, which leads to ischemia, and it completely exhausts itself, building up lactic acid.
Oh, wow.
Yeah, so it doesn't actually have the functional strength or the endurance you need for daily life, but the nervous system absolutely refuses to let it relax.
It's like clenching your fist constantly for 3 days straight until your hand completely cramps up into a claw.
That's a perfect analogy, yeah.
If you want to use your hand again, you wouldn't try to strengthen that cramped hand by aggressively squeezing a stress ball, right?
No, that would be agonizing.
You would have to manually force the fingers to let go, restore the blood flow, and rest before you ever thought about building grip strength. So, prescribing Kegels to a hypertonic pelvic floor is literally just feeding the pain problem. You are asking a cramped, exhausted muscle to contract even further.
Exactly. And the sources emphasize that before any functional strengthening can occur in physical therapy, the muscles must learn to relax. The brain has to, rewrite its software. And this is where pelvic floor physical therapists introduce down training.
Down training. And that involves a very strict clinical approach to force that relaxation, right?
Yes, very specific techniques.
One of the foundational ones detailed by the clinics is diaphragmatic breathing or deep belly breathing. But this isn't just about feeling calm or meditating, is it?
No, not at all. There is a very distinct biomechanical mechanism at play here. When you take a deep, localized diaphragmatic breath, the diaphragm physically flattens and pushes down on your abdominal organs.
Okay.
And that downward pressure physically and gently stretches and forces the pelvic floor muscles to drop and lengthen.
Huh. But the clinics combine this biomechanical breathing with external soft tissue work too, right?
They do, yeah. They use progressive muscle relaxation to reduce the global tension in the central nervous system. Because pelvic guarding is rarely just isolated to the pelvis.
Oh, really?
Yeah, if the jaw is clenched and the shoulders are up by the ears, the pelvic floor is likely locked up as well. It's all connected.
But the physical therapists don't just rely on touch and breathing. There is a pretty significant technological element used to rewire the software here. The sources heavily detail the use of biofeedback, specifically systems like the M-trigger device.
Yes, biofeedback is huge for this.
And this seems crucial because it makes the invisible tension actually visible to the patient.
Exactly. The therapist places gentle external surface sensors that measure the resting electrical activation of the muscles. So the patient looks at a screen and literally sees a visual meter, like a bar graph, representing their internal subconscious tension.
Which completely gamifies the relaxation process. I mean, if you can't feel a muscle because it's been numb and cramped for years, you can't just tell it to relax.
Right, you have no baseline.
But if you see the bar graph in the red zone and you use that diaphragmatic breath we just talked about, you can actually watch that bar graph drop into the green zone in real time.
Yeah, you are visually learning what relax actually feels like in your own body, which begins to break that cycle of reflexive clenching.
Okay, so the down training successfully addresses the software. It reteaches the brain how to stop constantly clenching the fist.
Right.
But logically, if we look at the whole system, down training alone has a glaring limitation. I mean, if biofeedback fixes the brain's habit of clenching, that is fantastic. But what if the reason the muscles are guarding and tensing up in the first place is because the actual mucosal tissue in that area is fragile, dry, or physically damaged?
That is the million-dollar question.
Right. If the friction of everyday movement against that unclenched muscle is still tearing dry tissue, the brain is just going to immediately relearn the clench to protect the area. Relaxing the muscle won't fix torn, atrophied tissue. How do we stop the physical tearing?
And that limitation brings us right to the transition point where biomechanics absolutely must meet regenerative biochemistry. When we look at the broader clinical picture, profound tissue fragility is often the root cause of the guarding in the first place.
The root cause. Wow.
Yeah. This fragility can stem from low estrogen during menopause, postpartum microtearing, or even just chronic inflammatory conditions. If that fragile tissue sends a sharp pain signal every single time there is friction, the central nervous system will automatically trigger the pelvic floor muscles to lock down like a fortress.
It creates a relentless pain anticipation loop.
Precisely.
So no matter how much deep breathing and visual biofeedback you do, if the hardware the tissue is tearing, the brain software is going to keep hitting the panic button. We have to fix the hardware. And this is where the clinical sources introduced the tissue-level solution, which is intimate polynucleotides.
Polynucleotides represent a massive, massive leap in regenerative medicine. We are finally moving away from temporary fixes like synthetic lubricants or dermal fillers and moving toward actual biological regeneration.
Let's get into the specifics of this because the origin of this treatment is just wild. We are talking about injecting natural, biologically active molecules made of highly purified DNA fragments, and these fragments are extracted specifically from the gonads of salmon or trout. Now, for anyone listening who is suddenly worried about becoming part fish, let's clarify the cellular biology here.
Yes, please. The first thing to understand is that DNA is a universal biological language. The molecular structure of the DNA in a salmon is made of the exact same basic building blocks, adenine, thymine, cytosine, and guanine, as human DNA.
Okay, so it's compatible.
Completely.
Yeah.
These injections are not permanent implants, and they are not hormones altering your endocrine system. They act purely as biostimulators.
So when these highly purified fish DNA chains are injected into the vaginal mucosa, the human body utilizes an internal mechanism called an enzymatic salvage pathway.
Right, the salvage pathway.
Yeah, our native tissue enzymes, specifically an enzyme called deoxyribonuclease, or DNase, recognize these foreign DNA chains and naturally begin to cleave them apart, just gradually breaking them down.
And the body then recycles those degraded fragments into free nucleotides. It essentially scavenges the fish DNA for raw materials and uses those base components for rapid cellular DNA repair in our own human tissues, right at the site of the damage.
It's incredible, and the biological mechanisms of action, which are detailed in the clinical FAQs from the Women's Health Clinic, happen in a few very distinct, measurable phases.
Yes.
The first phase is immediate physical hydration, right? Because the tissue in these hypertonic atrophic states is often severely dry and just starved of moisture.
Exactly. These specific polynucleotide chains are highly hydrophilic, meaning they attract and bind water molecules incredibly efficiently.
Yeah.
Once they're injected into the submucosal layer, they form a three-dimensional viscoelastic gel matrix.
A 3D matrix. So think of this matrix not just as a sponge soaking up water, but rather as injecting a microscopic, flexible scaffold that physically holds water molecules in place.
That's a great way to picture it, yeah.
It immediately restores physical hydration and volume to that dry, atrophic mucosa, providing the cells with a highly hydrated environment in which they can actually begin to rebuild.
And once that hydrated scaffold is in place, the cellular stimulation phase begins. The high molecular weight polynucleotide polymers actively bind to specific receptors on the surface of our cells, specifically the CD44 receptors.
And binding to those CD44 receptors acts almost like an alarm clock for your fibroblasts, right? The worker cells responsible for synthesizing new structural tissue.
Exactly. It wakes them up.
It forces them to upregulate the production of endogenous collagen. But what the sources really stress is that it specifically stimulates type I and type 3 collagen.
Which is vital.
Right, because it means the body is building healthy, flexible, functional tissue rather than producing fibrotic scar tissue, which would only make the area more rigid and painful.
The structural improvements are profound. But the sources also highlight a crucial third phase, which is vascularization and barrier repair. The polynucleotides actually stimulate the localized secretion of VEGF, or vascular endothelial growth factor.
VEGF, and that's the signal the body uses to grow new blood vessels, right?
Exactly. By stimulating VEGF, the treatment restores the microvascular capillary networks in the vaginal walls. It brings fresh, oxygen-rich blood and vital nutrients back to tissue that has been ischemic and blood-starved due to years of that muscle clamping.
Wow. Furthermore, the treatment supports the repair of a tight junction protein known as claudin-1.
Yes, claudin-1 is so important here.
If you think of your cellular walls, claudin-1 isn't just mortar between bricks. It acts more like a biological sealant, tightening the cellular ziplock. By repairing this specific protein, polynucleotides restore the natural, impermeable barrier function of the vaginal epithelium.
Which is what stops the pain cycle.
Right. This makes the surface tissue incredibly resilient to friction and vastly less prone to micro-tearing.
The theory and the biological mechanisms are undeniably sound, but the real-world application is where this gets truly fascinating. And this brings us to the clinical study published in the journal OA Text.
Right, because this research wasn't just conducted on isolated cells in a petri dish. It tracked a real-world cohort of 54 women.
Yeah, 54 women. And these women, a mix of menopausal and non-menopausal patients, were all suffering from severe vulvovaginal atrophy and the resulting pain. The study had them use a daily polynucleotide-based vaginal ovule over a period of 2 to 4 weeks.
And they used the Vaginal Health Index to measure the outcomes, tracking specific parameters like elasticity, fluid volume, pH levels, and epithelial integrity.
The quantitative results were highly significant. I mean, the investigators recorded a 59.8% improvement in vaginal hydration, which directly correlates with the formation of that 3D viscoelastic gel matrix we discussed.
Almost 60%. That's huge.
Yeah. And they also documented a 52.7% improvement in natural vaginal secretions.
But the most striking metric in the OA Tech study, to me at least, was a 51.6% reduction in superficial petechia.
Oh, absolutely.
And for you listening, petechia are those tiny superficial micro-bleeding spots that occur under the skin when extremely fragile tissue is stretched or touched. Seeing a 50% reduction in those bleeding spots proves that the claudin-1 barrier is actively thickening. The tissue is literally getting stronger and resisting the tearing that triggers the pain response.
And the study noted all of this was achieved with no severe adverse effects. It represents a massive shift in the quality of life for these patients.
So we have a clear picture of the two components. We have physical therapy down training to fix the guarding muscles, the software, and we have intimate polynucleotides to regenerate the fragile, tearing tissue, the hardware.
Exactly.
Which brings us to the core focus of our deep dive today. What is the actual clinical approach for combining intimate polynucleotides with pelvic floor down training for someone locked in a hypertonic state? How do clinicians actually merge these therapies in practice?
Well, if you look closely at the clinical sequencing protocols provided by the Women's Health Clinic, the golden rule is actually the absence of a rigid rule.
Oh, really?
Yeah, there is no published patient use protocol or one-size-fits-all checklist for combining these therapies. The entire clinical approach must be assessment-led.
So the clinician has to act as a diagnostic detective to determine the primary driver of the dysfunction in the individual patient.
Precisely. They have to ask, is it profound estrogen-depleted tissue fragility that is constantly triggering the muscle to guard? Or did a primary muscle spasm, perhaps from a biomechanical injury, create so much constant friction and restriction that the healthy tissue eventually broke down?
Right. And every patient's timeline will shift based on that diagnostic answer. However, regardless of the origin of the pain, the clinics strictly enforce a concept known as pain-aware sequencing.
Yes, pain-aware sequencing is non-negotiable.
And that means heavily cautioning against stacking multiple invasive treatments on the exact same day.
Correct. If a clinician puts a patient through an intensive hour-long internal pelvic floor down training session and then immediately subjects them to a series of intimate regenerative injections, they completely blur the diagnostic lines.
Yeah, if that patient goes home and experiences a severe flare-up of pain the next day, the clinician has no idea what caused it. Was the physical manipulation too aggressive? Or did the injections cause a localized inflammatory response?
Exactly. Staging the treatments ensures that consent is clear, comfort is maintained, and cause and effect can be accurately tracked.
So because there isn't a rigid checklist, the successful sequential protocol for someone locked in a tight, painful state generally follows a specific multi-month narrative arc.
It does, yeah.
Let's walk through what that hypothetical patient journey actually looks like. Generally, the clinical approach starts by addressing the software. In month 1, down training and pain modulation are initiated by the physical therapist.
Right, starting with the software.
If the hypertonicity is severe, therapists will often utilize peripheral acupuncture to help manually de-guard the muscles, just so the patient can tolerate the insertion of a biofeedback sensor or even a basic physical examination. You have to quiet the blaring alarm bells in the central nervous system before you can do anything else.
The physical therapist is trying to get that perpetually clenched fist to open just a fraction of an inch. And once the muscle tone is somewhat receptive and the patient actually understands the mechanics of diaphragmatic relaxation, the clinical approach shifts to the hardware.
Okay, so in month 2, the intimate polynucleotide injections are carefully staged. By injecting these fish DNA biostimulators into the submucosal tissue, the clinician starts repairing the structural damage that the clenched muscles caused.
And as the CD44 receptors trigger new type I and type 3 collagen growth, and the VEGF restores the micromuscular blood flow, the physical compliance of the tissue rapidly improves.
The tissue gets thicker, stronger, and highly hydrated. Crucially, it stops sending sharp pain signals to the brain every time the patient moves, walks, or engages in intimacy. The hyperalgesic or exaggerated pain response is completely muted.
The cellular ziplock heals, and that healing physically breaks the pain anticipation loop. The brain finally stops telling the pelvic floor to guard because the threat of tissue damage is just gone.
Wow. And once that feedback loop is broken, the protocol moves into month 3, returning the focus to the physical therapist. Now that the tissue is structurally sound and the resting muscle tone has been normalized through biofeedback, the physical therapist can finally progress the patient.
Yes, finally moving forward.
They move from simple down training to coordination exercises, teaching the muscles how to properly turn on and off during daily functions, and eventually they can move into functional strengthening. But the crucial clinical takeaway is that the strength only comes after the relaxation and the tissue repair are entirely complete.
It is a complete paradigm shift in intimate health. Treating pelvic floor dysfunction, particularly dyspareunia driven by hypertonicity, requires a holistic clinical approach. You have to respect both the biomechanical reality of muscle tone and the biochemical reality of cellular tissue health.
If you are dealing with chronic pelvic pain, the takeaway from this deep dive is that you shouldn't accept a single, isolated quick fix. If your physiotherapist is helping you successfully relax your muscles using biofeedback, but you still have severe estrogen-depleted tissue fragility causing micro-tearing, you shouldn't drop the tissue treatment just because the muscle feels a bit looser.
Right. Don't ignore half the equation.
Conversely, regenerative injections alone won't magically uncramp a hypertonic muscle that has been guarding your pelvis for 5 years. It requires respecting the whole system.
We've seen how our body's own enzymatic salvage pathways can literally recycle DNA fragments from fish, using them as raw biological materials to rebuild vaginal tissue from the ground up. And that biological reality leads to a final thought I want to leave you with today.
Oh, where does the science point us next?
Well, if enzymes like DNase can break down salmon DNA and perfectly repurpose it to rebuild the human vaginal wall, it forces us to ask, what other dormant salvage pathways are waiting in our bodies to be unlocked by the right biological keys? Right. If we can stimulate our own fibroblasts to rebuild structural tissue on demand using natural nucleotides, are we looking at the beginning of the end for synthetic implants, meshes, and foreign fillers entirely? The future of medicine might not be about putting new artificial hardware into the body, but simply giving our existing cells the exact raw code they need to heal themselves.
It's an incredible thought. It really changes how we view the capability of our own biology. Thank you for joining us on this deep dive. Keep questioning the standard advice. Remember, Kegels aren't always the answer. Keep learning about the incredible science happening at the cellular level. And remember that when it comes to the human body, absolutely everything is connected.